Hello, welcome to this online presentation on pharmacy services and safer prescribing, and welcome to Lister Hospital as well. My name is Rachel Holland. I'm one of the education and training pharmacists. So usually I would be doing this training in a group setting in the LEC, but obviously we've not been able to do that this time. So I hope that this recorded version of this presentation with me talking over the slides is useful to you. I can email you a PDF copy of these slides if you would like that as well. My email address is on the last slide, so I'm very happy to do that. Also, if you want to ask any questions, then please do so. We have also got some prescribing exercises and other talks from the antimicrobial pharmacist as well, so hopefully we'll be able to pull all that together in the coming weeks to support you in your new role at Lister. So this talk covers basics about the pharmacy department and about understanding our role and how it's relevant to you guys. We'll be focusing on some prescribing standards and some clinical topics, things like oxygen, VTE prescribing, methotrexate prescribing, to name a few. And then we'll also be looking at things to do with clinical decision making as well. So I thought I'd put my face up on the first slide just so you can sort of put a name to a face, not this sort of hovering voice, but I'll minimise myself now and just talk you through the slides, and then I'll bring the camera up again in the last slide. So this is the first slide. Where are we? So we are on level 3, just before the lifts, so we're opposite pathology. If you do want to come to pharmacy, then come through to the staff entrance. We've got 2 entrances, a staff entrance and an outpatient entrance. So obviously don't join the queue or go in via outpatients because that will slow you down a lot. Come to us via the staff entrance. Having said that, please don't drop off work to us on a weekday without prior agreements, because we do operate as a chart-free dispensary, so we want all the drug charts to be where they should be on the ward, so that if any patients need pain relief or critical medications, then they're not chasing around searching for them because they're in pharmacy. So for that reason, please don't drop off work to us without prior agreements. Weekends are a little bit different. We do try and get onto the wards, but we are a smaller team. So if you have written a TTO, particularly if it's a bit later and you want to drop it off as on the way out somewhere or on the way somewhere, then that's usually okay. But weekdays is not without prior agreements. We've got our opening times there for inpatient work. As you can see, Saturday and Sundays are much more restricted than weekdays, just because we do operate with a smaller team. Sundays is supposed to be more of an emergency service as well, so we'll do TTOs and we will do inpatient items, but it is a smaller team. So we do like the majority of the work to get done on the Monday to Saturday basis. We have a separate outpatient pharmacy, so it's a subsidiary company called ENH Pharma. So this is where our clinic patients will go. So if they get given a hospital prescription, that means they have to bring it to ENH Pharma. They cannot take it to an outside pharmacy. It will not be dispensed by them. Okay, just a little bit now about how to contact us. Communication is so important. You know, if you prescribe an urgent drug, tell us. If you write a TTO, ideally, if we're there, put it in our hand. If you want us to check a TTO over, we're more than happy to do that. And if you have a question, just don't be afraid to ask. So get to know your ward pharmacist. Generally, they'll be there at least once a day. Some wards, they'll be there pretty much all day. And if they're not there, then they'll be available either via a bleep or sometimes via a mobile that sometimes the ward clerk will have access to. If you really need to ring the dispensary, then that's extension 5510, but just bear in mind that it does slow us down quite a lot if we do get calls through the dispensary where they don't really understand what you're talking about because they're not the ward pharmacist that knows the patient. So just try and bleep your ward pharmacist at the first point of call, even if it's to ask whether something's ready yet. If you have more of an in-depth clinical query, which your ward pharmacist if you can't get hold of them, or you think that it's very in depth and you want an audit trail and you want maybe some written information sent to you, then Medicines Information is a good place to contact. They're available on either an extension or a bleep 4969. Medicines Information, like I say, it is more for complex queries. They generally don't give you an answer there and then, because if it was that simple, the ward pharmacist would be able to do it, or you yourself would be able to do it by looking at a range of easily accessed resources. They're generally for very complex queries where we might have to look at a real range of different resources, maybe contact specialist centres, and then use our sort of clinical judgment to come to a bit more of an answer. So as you can imagine, that takes time. So only put queries through Medicines Information if you're aware that you're unlikely to get a snap answer. Your ward pharmacist is the best person to go through if you want a really quick answer, and you don't need an audit trail for it. Contacting pharmacy out of hours now. So we are a 24/7 service. We do have emergency duty pharmacists. We are an on-call service, which is different to a residency service, which they have in some hospitals. So we do only come out for critical drugs where the duty matron can't source it from anywhere else in the hospital, or TTOs only if there is a bed crisis, or if there's some kind of unusual compassionate circumstance, like they need to get a patient to a hospice or something like that. But generally not for TTOs, it's generally for critical items that can't be sourced elsewhere. We're also available for advice, but we say registrar or above. So if you do need some advice from a pharmacist, then contact your MedReg or your senior doctor colleague first, and then if they don't know the answer and they need to contact pharmacy, then they can, and we'll answer that phone call. Little bit more now about our role on the ward and how it's all relevant to you and how we can work with you as part of the MDT. So we are responsible for medicines reconciliation. So if you've not heard that terminology before, it's basically like a drug history, but a medicines reconciliation means that everything the patient was on before they came into hospital, they should be on now. And if they're not on it, for example, it's been stopped for some reason, then that has to be clearly documented in the notes and on the front of the drug chart, so that any other team or any other person picking up that patient can see exactly what they're on and what changes have been made to their medication when they've come into hospital. Generally, our MMPTs, which stands for Medicines Management Pharmacy Technicians, will do quite a lot of our medicines reconciliations. So that frees us up as pharmacists for more clinical work. So we will be clinically screening every medicine on that chart to check it's correct in terms of the dose, its appropriateness in the current clinical context, any interactions which might be problematic, patient compliance, any administration issues, to name a few. And we'll also look at medicines optimization, so things like deprescribing, improving inhaler technique, patient education, if they're refusing medication, and things like that. I'm going to move on now to some prescribing basics. So write in blue or black permanent ink. That it's quite important that you don't write with a fountain pen. I have seen some doctors doing it. It does look very nice until you get some sort of water for injections or lactulose or something like that spilt all over it, and then unfortunately it becomes an illegible mess. So if we can try and keep prescribing to permanent ink, so a ballpoint pen, then that is the best for that reason. EPMA was about to come in before COVID, and it was going to start on one ward and then spread out to others, and hopefully this project can recommence soon, but haven't had any concrete dates yet. So we are, for the moment anyway, stuck with prescribing by pen. So drugs should be prescribed generically using the full name. there are some exceptions to this. So if it's brand specific, if it's really significant which brand the patient should receive in the case of tacrolimus, for example, so you've got on the screen here the Prograph or the Advagraph, you can put tacrolimus as well, but make sure that the brand is on there because that is important. Insulins should also be prescribed by brand, just because the nurses are more familiar with them that way. Any inhalers should be prescribed by brand ideally, anti-epileptics. The other thing we ask you to do is make sure when you prescribe something that your bleep number is at least somewhere on that chart. So if you do the Clarkin prescribing and you're going to write out about 8 medications, if you can add your bleep number at least maybe to the first one, or if you're coming to a chart and prescribing something new on it, if you can add your bleep number. And that means that we can resolve any problems quickly, we can prevent patient harm. And it's good for your development if we can sort of communicate with you if there's something that's perhaps maybe not being done quite correctly, or maybe if we want to clarify something, then if we have a really quick way of contacting you, then that's good for everyone. So the next slide is handwriting. So like I said, unfortunately, until EPMA is launched, we are at the mercy of people's handwriting. We've got just a few examples here of pretty illegible handwriting. It is an inexcusable patient safety risk, really, so we need to make sure that it's legible. If you know that your writing is a little bit tricky to read, then write in block capitals and just make sure that other people can read your writing. We have 2 main types of prescription charts. So if you haven't seen this already, the white one is for non-diabetics and the blue one is for diabetic patients. If you work in other areas like paediatrics or critical care, they will also have their own different drug charts too. So hopefully as well you've had a little chance already to familiarise yourself with all the sections on the drug chart so that you know where to prescribe different items. With the non-diabetic charts, if you flip over to the first page, you'll see all the BT assessments and the prescribing parts. You'll see that there's a separate page for the anticoagulants. You'll also see there's a separate antibiotic section and separate fluids sections. The diabetic chart is the same, but with added sections as well. So there's a separate subcutaneous insulin prescribing and administration page. And there's also pre-printed VRII prescriptions there as well. So hopefully that makes it really simple for you to prescribe those medications. And it has also really helpfully actually got space for the nurses to put in the blood glucose results. So that means that you can at a glance check whether they are well controlled or whether they might need some adjustments to their insulin therapies or drug therapies. Okay, so at the front of the drug charts, just want to highlight a few sections here. They're not always filled in very well, but we know from when we have CQC rounds that if they find a lot of sections that are consistently not filled in, then they sort of like to grumble about it. And it is helpful to us as well. It's not just for no reason. So make sure that we have all the patient's details, first of all, that we have ideally an addressograph, because that's the most accurate. It would be helpful if the renal impairments bit was ticked. It just flags that this is a renal patient. The allergy section must be signed and dated before you prescribe anything. We also tell nurses not to administer anything until that allergy section has been filled in, and I will talk about that a little bit later. The date of birth, height, weight should also be filled in. If it's not possible to weigh the patients, then you can add in an estimate as well. So again, just a little bit more about our prescribing standards here. If you're making any changes to a dose, for example, like it has been at the front of at the top of the drug chart here, where they've prescribed some furosemide and they've changed it from just in the morning to twice a day, they've stopped it, signed it and dated it, and then they've rewritten it as well. So that makes it very clear who has prescribed the increased dose, when they prescribed the increased dose, and it just makes it a bit clearer when you're making clinical decisions about, okay, when do I maybe need to increase it even further, or oh, this patient's developed hypokalemia, could that have been due to an increased dose? It just makes it very clear when that dose was changed. Just going down on the left-hand column, using the blank boxes instead of doctoring the numbers is good practice as well. So you can clearly see that the MST 20 milligrams BD is given at 8 o'clock in the morning and 8 o'clock in the evening, because there isn't an 8 o'clock time already pre-printed. They've just put it on the side and they've circled it. So if you can keep to that. Going down the right-hand column now, I have already spoken about the signing and dating when you cross anything out. Don't amend times, like I've just said. The cholecalciferol prescription, as you can see, has been nicely prescribed here because they've blocked out all the days that they don't want the patient to have the medication, and they've put a very clear box around the days where they do want the nurses to administer the medication. So it's pretty foolproof to any nurse looking after this patient when exactly what date they are giving this medication, and make sure that the start date matches up to everything as well. So when you are redoing the drug chart, for example, don't put the dates that you're rewriting the drug chart, write the dates when it was started. Okay, so notes about clerking and allergy status now. Obviously, as I've said before, the allergy status must be completed before anything is given to the patients. We do specify that you do need to use a minimum of 2 sources. So generally this would be the patient if they have capacity, and maybe a GPSCR. It doesn't have to be those 2 sources. But if the patient does lack capacity, use the relatives, use information on Lorenzo, nerve centre, any nursing home medication records, so we'd call that the MAR chart, in addition to the GPSCR. And if anything changes, then update Lorenzo on discharge. The reason why we're being quite clear about this, about our expectations with allergy status, is because we have had a recent SI in the trust, a serious instance, where a patient with a serious teicoplanin allergy was given teicoplanin, and they actually died as a result. And when it was looked into and investigated, as you can imagine, it was heavily investigated, it was found that the doctor only used 1 source for the allergy info, and if they'd actually cross-checked that source against another source, they would have seen that the teicoplanin was there. So unfortunately, it's taken that instant for us to learn from that and make sure that we are using 2 sources for checking allergy status. So talking a little bit further about the SCR, just some tips really, some bit more information, because the SCR is very helpful, but some of the information on it might need some interpretation, or you might need to cross-check it using the patient or another source. And don't rely too heavily on it as well. Clerking is not all about the SCR. Patients themselves are a very good source to actually match up if they take something like the SCR is prescribing. In some circumstances, well, in a lot of circumstances, when I've been talking to the patient about what's actually written on the SCR, they're taking it completely differently. So make sure you do use the patient, check if they've brought in any medication with them as well, because that's always a good clue as to how compliant they are. If you can see something that's was dispensed 4 months ago and it's still a complete pack, then that you may think that perhaps this patient isn't very compliant. There may be a good reason for it, but it's just something that might flag to you. You can also use MAR sheets. That's a really accurate source to use for clerking. And just bear in mind when you're looking at the SCR, it doesn't list everything. So if a patient's on chemo, or they're on clozapine, or they're receiving drugs from a memory clinic, chances are it won't be on the SCR. So yes, the SCR is brilliant, it's really useful, it's our primary source for medicines reconciliation for pharmacists as well as doctors when they're doing their clerking, but it's not everything. Don't rely on it fully. So just to go through the points on the slide, check the recent medicines as well as the repeat medications. Obviously, anything that's over 3 months old, the patient probably isn't taking, and it becomes less relevant the less recent it is. But things like, you know, if they've had an antibiotic a week before they've come in, and obviously it hasn't helped with the infection because they've come in, well, that sort of suggests to you, well, okay, let's not prescribe that same antibiotic because they've already had that and it hasn't worked. So it's really useful to look at that section. Take a note of anything that's been recently discontinued. It might be relevant. It might be the cause of them coming in. Check the last issue date, but don't draw too many assumptions from it. Sometimes if you can see that something's not been issued for many months, it may mean that there's a compliance issue, the patient's not taking it for whatever reason. Or it may not be, it may be you might see something like warfarin and it might say never issued, but actually that's because they had it dispensed from the anticoagulation clinic or from somewhere else. So yeah, like I say, just don't make assumptions. Once a week medications, helpfully on the SCR, it very rarely lists the day of the week that they take it. So something like alendronic acid, for example, you'll need to check with the patient what day they actually take it and make sure that you prescribe that to reflect that on the drug chart and block out the days that they're not taking it and box the days that they are taking it. Insulin doses, SCRs are notoriously unhelpful when it comes to insulin doses, because it will just tell you the concentration of the insulin in the pen, and that can be misconstrued, and you sometimes see these massive doses written up. But actually, it very rarely will they say what dose the actual patient is taking. For you to write that up on the prescription, you will need to check with the patients, who are normally the best person actually when it comes to insulin doses, because they're normally completely on it and they know exactly what they're doing. If there is any problems in that regard, if they have come in with confusion and you can't check with any carers that might know, then the best thing really to do is to seek specialist advice from their diabetic team, because they might need to start insulin infusions or monitor BMs and then make decisions. But you know, you obviously don't take that on yourself, but you know, most of the time the patient will be able to tell you, and it's fine. So have a look at the PRN meds as well. We sometimes get problems with this where doctors write up everything on the regular side, even though actually the patient doesn't really use it and it's just a PRN med. And also just think about what you're writing up as well. I've quite regularly seen sildenafil for erectile dysfunction, not for any other indication, written up on the drug chart. Well, clearly they're not going to need that in hospital. So just look at every item and just check whether they need it, whether they need it in a PRN capacity, whether they need it in a regular capacity, and what the best thing to do is. And just think about the appropriateness of the medication in their current clinical condition, because what might have been correct for them 2 weeks ago, even 2 days ago before they came in, may not be appropriate for them now. So for example, ACE inhibitors in the context of hyperkalemia, lithium in the context of an AKI, obviously these things need to be withheld. So you should document that, and in the notes and also on the front of the chart, and don't just sort of blindly copy out the lists, just sort of mindlessly doing it. Okay. I want to have another sort of story here for you now about the importance of clarity and about something else that happened in our trust fairly recently. There was a patient who was unfortunately given dalteparin twice, and then they ended up passing away from a bleed. The reason this happened was because a doctor had prescribed 1 dose of this dalteparin on the stat side, and then they'd written another dose in the VTE section for the next day. The doctor had actually done everything correctly. It was the nurse that misinterpreted it. They didn't see the stat dose on the front of the charts, which had actually already been given. They just went to the VTE side, saw the date and just thought, oh, they've just put in the wrong date, manually changed it and then gave the dalteparin. So when we're sort of looking back at this issue and thinking about how could we have prevented this happening, how could the prescribing doctors have made it totally clear? And what we think the best thing to do in situations like this, whether it's an antibiotic, whether it's a dolteparin or something like that, if you've put a stat dose on the front of the drug charts, and then you're putting more doses in the main section of the drug charts, is to actually write the date in the main section of the drug charts that you've already given the stat dose, and write in the box or below the box C stat, and then write the next dose, the next day, and box it round. And then the nurse clearly, when they're looking at that, can say, oh, I'm not, or the doctor hasn't made an error with the dates, it's already been given, I don't need to give it, it will be given tomorrow. So just a little note about the importance of clarity there. A little note about patient's own drugs. I don't know if you've seen these sort of green bags which contain medication which the patient has brought in. So if you are working in any acute setting and patients are bringing in their own medication, please don't tell relatives to take it back with them. We do want their own medication with them in hospital. It saves us money and time, so that we don't have to dispense these items and that they get their medication on time. It's also a really good source for us to look at what's going on with their medication and use it when we're doing medicines reconciliation. If you're using the medication though as your only resource when clerking, which is never advised, just be aware that we have had incidents where, for example, we've had a patient that had 5 different medications written up for them, none of them actually belonging to them. It just turned out that a nurse had cleared out a cupboard and somehow this bag had got transferred with this patient to a different ward, and the doctor just wrote everything up onto this drug chart. And it was only a few days later when the consultant was on their ward round and kind of spotted that the indications that the medication that these patients were on, the patient didn't actually have these conditions. You know, they were written up for antipsychotics and there was no history of anything like that. So, and then it was kind of thought about what actually happened. So yeah, just bear that in mind. What can pharmacists do? So it very much depends on whether the pharmacist is a non-medical prescriber or not. So if they aren't a prescriber, then they can only make simple amendments or additions to a drug chart or a TTO. So we can do things like, if it's very clearly and very obviously wrong, we can stop duplications of things like paracetamol. But in most cases, we will need to contact the prescriber. Prescribing pharmacists have the same legal powers as doctors. They can prescribe medication onto a drug chart or complete TTOs, but obviously if they're changing something important, they wouldn't just do that without the communication with the team. So remember, if someone asks you to sign for something or to prescribe a drug that you're not sure of, make sure that you are aware of your own limitations. Don't sign for something if you're not sure about it. Please feel free to say, I don't think I can do that yet, or I want to find out something, I'll come back to you on it, rather than signing for something and taking a legal responsibility for something if you're not actually very sure about it. I'm going to go on to a few clinical topics now, as promised. The first one of these is oxygen. So the take-home message for oxygen is that it is a drug, and therefore it must be prescribed for all patients. It's really not good clinical practice if we're going around wards and we can see patients are clearly on oxygen and it's not on the drug chart anywhere. So it is easy to prescribe. All you need to do really is circle the required target range, state the device and flow rate, whether continuous or PRN, and that's about it really. We have a really good respiratory nurse or oxygen specialist called Jane Conway, and she's available via switchboard, or you can email her on janeconway@nhs.net. She's our oxygen kind of champion. She's very, very good, and she's really happy to answer any questions you've got. So I would refer really any sort of more complex oxygen queries to her, because she's really good. Moving on to VTE assessments and reassessments now. So hopefully our chart is fairly intuitive if you've had a chance to have a look at it already. In our various updates of the charts, we've tried to make it more and more robust. So it's a scoring system. We're basing it on patients' risk factors for thrombosis and then for bleeding. And then it clearly shows what to do once you've got that score. What I would say is that it's very important to reassess. We're quite good now. We're really quite good on doing the VT assessments. It's not often that I come around drug charts and see that it's not been done at all. But what we do need to work on is our reassessments, because there may be a need to start or stop low molecular weight heparin during the admission, sometimes even several times. If you've had a patient that's come in with a bleed, but then a few days later they're not bleeding and they have got quite a significant thrombosis risk factors, it's then the clinical decision to reassess the patient and decide, okay, are the thrombotic risks now more significant than the bleeding risks? Do we need to get them on dolteparin? So we need to have evidence of this clinical decision making in the form of these reassessments. You need to sign and date each risk assessment. And yeah, we need to reassess within 24 hours, and then when the clinical situation changes, or every 7 days if they're stable. For elective admissions, the VTE risk assessment is carried out in the preoperative assessment clinic. But we do need to reassess post-op, and then again if the clinical situation changes. If extended thromboprophylaxis is anticipated to be needed after discharge, then we do have a separate part on our chart for doctors to state this intention. Please make sure you sign that and date that, and then that means that on discharge, on the TTA, if it goes down to pharmacy, we can clearly see that if it was missed, okay, actually it shouldn't have been missed. We do need extended thromboprophylaxis. So hopefully that is clear. Any questions, then please get in touch. Fluid prescribing next. I haven't got very many slides on this. It's just the basics really, but it's just to say that our fluid section is quite detailed on the drug charts. We do encourage documentation of electrolytes from the patient's blood results, so that we can really tailor our fluids to the needs of the individual patients. Our routine maintenance fluids is 0.18% sodium chloride, 4% glucose, 20% potassium. But we have got a range of fluids available if you need something more specialist. For patients that are on insulin infusions, they may or may not need more potassium because of the effect of insulin driving the potassium into the cells. So we do have a different maintenance fluid for those patients, which is the 0.45% sodium chloride, 5% glucose, and 20 or 40 millimoles of potassium. And for resus, generally we use either Hartmann's or sodium chloride. Moving on now to controlled drug prescribing. As it says on here, it is a common cause of delays, unfortunately. It is a bit of a headache, but once you've got your head around it, it is actually pretty simple. And these legal requirements will be the same anywhere you work, so you might as well get used to them right at the start of your career, really. All we need from a legal sense is that you've got the name, the strength, and the form of the medication, and the dose. So the dose legally cannot be PRN. It has to state an actual dose. So for example, if they're having Oromorph, it would have to say 10 milligrams up to 2 hourly or up to 4 hourly. It can't just say PRN as a blanket. They can take however much they want, whenever they want. The total quantity needs to be in words and figures. I have seen things where doctors have written everything out in words and figures. It's only the quantity. So it's like writing a check, probably don't write many checks these days, not very common anymore, but if you just have that in your minds, so it's 60, this example here, this morphine sulfate, and then they've written out the word 60, they've written the name of the tablet, the strength of the tablet, and the form of the tablet as well, the SR tablets, and there's a few examples there. The number of classified CDs are ever growing, so now tramadol, temazepam, pregabalin and gabapentin are also CDs. If the patient has brought in enough, or they have confirmed that they've got it at home, then you don't have to write out all the total quantity in words and figures, because we wouldn't need to supply it. We would just write at home or returns to patient, PODS returns to patients. So it's only if we are actually supplying it that we need this total quantity in words and figures. And if you're not sure, then if you're not sure whether we need to supply or not, just write the total quantity in words and figures, and then we will take it from there whether we actually need to supply it or not. If you're writing out quite a complex CD, or even not a complex one, even if it's just the first few ones that you're writing, and you want a pharmacist to check it over or sit with you whilst you're doing it, we would be more than happy to do that. We'd much prefer that than having to sort of track you down later on and having delays for our patients, because bear in mind, these prescriptions do take longer for us to dispense in our pharmacy. So don't make promises to patients that are on a lot of CDs. Oh yes, you can go home, you'll be home within the half hour, because it does take a while in pharmacy. And then bearing that in mind, write the CD TTOs first. If you know you've got quite a few to write those CDs first, because we can then get that down to pharmacy and get it in the queue. We can't dispense it on ward level like most of our TTOs. It has to go down to pharmacy. So that's another reason why it does take a bit longer. So opioids as potentially risky drugs, obviously they do have this respiratory depression side effects, which has come to light with some serious incidents in the trust in the past, one of which was involved with fentanyl patches, where the doctor just didn't quite realise how strong they are, and they just put a patch on this patient who ended up in respiratory depression. They had to go to ITU. They were an opioid naive patient. So we have to bear in mind with fentanyl patches that they are strong. So a 50 microgram patch is equivalent to having 120 milligrams of morphine a day. They are only for chronic stable pain. They're never for opioid naive patients. So if a patient is being initiated onto a fentanyl patch, it's our trust policy that only a consultant can do that. Obviously you can write it up if the patient came in on it, but any initiation must be a consultant only. Similarly, alfentanil is an extremely potent opioid. It's between 15 and 20 times stronger than morphine, stronger than diamorphine as well. So 50 milligrams of alfentanil can be like 1,000 milligrams of morphine. It is really, really, really strong. So you should never really see 50 milligrams of alfentanil. It's usually sort of 5 milligrams of alfentanil, if that. So the trust policy with this is that it's to be prescribed in ICU or palliative patients only. It's not something that as junior doctors you should be initiating and prescribing. It's a very sort of specialist opioid. A little bit now about communication and documentation. Hopefully I've sort of made clear in the slides how important communication is, and how we really want you to communicate with us as much as possible, and us with you as well. We need to make sure that all relevant people know the plan for the patients, that it's documented clearly in the medical notes. Bear in mind that communication with the GP is via the electronic discharge letter. That is all they get. So sometimes, we have calls through to the medicines information helpline from GPs who are completely confused because they don't understand if something has been stopped with their patient intentionally or not intentionally, because it's just not mentioned on the letter. So try and make that as thorough as you can. Also be aware that many members of the MDT write in the notes. Please don't ignore it. If pharmacy or anyone else writes in the notes, please bear in mind what they've said. If you've prescribed something urgent or stats, I think I've sort of mentioned this before, tell us, tell the pharmacy staff, tell the nursing staff, don't just write it and then walk away, because it could be hours before that medication is actually given. And again, I've said this before, but I'll say it again, please include your bleep number, particularly on TTOs. There isn't there isn't a prompt for you to do that, so it's just going to have to be you kind of getting in the habit of doing that. But it really, really helps us if we can contact you easily, because any little problem or any big problem can be sorted out so much quicker, and the patient flow of patients through the hospital is that much quicker if we can get patients discharged as quick as possible. A little note whilst we're on the subject of TTOs. Obviously I've talked about the delays that can be caused. Write them early, so it's far quicker to update things nearer to discharge if needed than to start from scratch. Even if you haven't done the letter parts, you can get the TTO part done. Non-medical prescribing pharmacists can support with TTOs on quite a few wards now, so if you know that a patient needs to go very urgently and you can't do it, then the site office can contact an NMP and try and get one of those to help on the ward. If their patient has stayed for less than 24 hours, it's actually 48 hours now, and they've had no changes to their medication, then they don't need a TTO. So obviously that will speed things up massively. When you write your TTO on the Lorenzo system, obviously you need to transcribe all medication the patient requires on discharge, including the regular medication, not just what you've started or what you've changed. Make sure you look in the insulin section and the warfarin or the NOAC section, because they're in separate sections. Sometimes they're missed, but obviously they are critical drugs. State the length of short courses or when things need to be reviewed. Don't worry about the supply section. We will do that. List the stopped medication or any changes in the comments boxes. If it's new, clearly write new in the comments box. And then you need to print it, sign it, and leave it for the pharmacist to check. Because it's an electronic system, sometimes we've had doctors that have clicked it and think that it electronically gets sent to pharmacy, and in our hospital unfortunately it doesn't. You do need to print it out, sign it, and then hand it to a member of the pharmacy team, or leave it for a pharmacy team for when we get onto the ward. We will make any amendments. Sometimes we'll have to go through the prescriber. If it's little small things, then we won't, and we'll add all of that information to Lorenzo. The minimum supply is 2 weeks. That's our sort of standard supply, and then the GP should take over. But make sure you adjust this for courses. So things like if the patient needs a couple more days of their Sandoz, or they need a course of antibiotics, or they need a course of steroids. We quite frequently see doctors that have obviously sort of just been on autopilot writing 2 weeks, and actually they need to specify exactly how many days we need. Okay, there are quite a few important trust policies which are available in the Knowledge Centre. There are quite a few, so I just want to highlight a few of them. So we've got methotrexate, and we'll go on to methotrexate on the next slide. Critical medicines, so hopefully that's like a sort of obvious what a critical medication is: antibiotics, anti-Parkinson's medications, things like that. We have got a policy on potassium chloride, gentamicin. I've got policies on oxygen, VT assessments and thromboprophylaxis, and many more. So if you're ever in doubt over what to do about something, just check if there's a policy on the Knowledge Centre, because they are very, very helpful, and they're really clearly written as well. So as I've mentioned, I will talk about the methotrexate policy. We have had a number of serious incidents in the trust to do with methotrexate. So now on the latest revisement of the policy, we now do not prescribe methotrexate unless it has had authority approval from the relevant specialist team. So whether it's gastro, dermatology, rheumatology, they must come and review the patient and decide if it's still appropriate. And they have agreed to do that even for patients that are not normally under their care. They will come and review the patients. So we do not administer it, we do not prescribe it, and we tell the nurses not to administer it unless the pharmacy checklist is completed and attached to the drug chart, but please don't prescribe it. If you feel that it's important for the patient to have it, then you get those specialist people to come and review the patient, and then they can prescribe it and clearly document that in the notes. We do feel that it's safer to miss the dose than potentially give it inappropriately, because as I've said, on the last serious instance, everything was done correctly. It was prescribed correctly, it was prescribed as a once weekly dose, but the reason why the patient came to harm was because they actually had a massive infection. I think they're a bit neutropenic, and obviously it just wasn't clinically appropriate for them to receive their methotrexate, and so this is why we treat methotrexate in this way. So have a read of the methotrexate policy, which will state in a bit more detail basically what I've just said then. For critical medications, so obviously there are drugs that must never be missed or delayed. Why are they important? So patients can become very quickly unwell if they're omitted or delayed. We tell nurses it's completely unacceptable to put a 4. A 4 is code for medication unavailable for a critical drug. We tell them that they need to escalate it to the duty matron, that they need to find it from somewhere in the hospital, or if it's within hours, they contact the ward pharmacist. If it's out of hours, then they contact the on-call pharmacist who will come in to supply it. If the patient is declining it, or they're nil by mouth, or they're vomiting, again, we can't just leave it, we must escalate it, and as doctors you must act to take charge of patient safety, and just come up with a plan. So okay, can we put patches on them instead, or do they need cannulating, or can we change the carbamazepine to carbamazepine suppositories, that kind of problem solving thought process. We have had examples of patients where they're taking things like tacrolimus. There was a patient that was taking this for a kidney transplant. They came in, they were nil by mouth. They cited an NG tube, but they were waiting for quite a long time for X-ray confirmation that it was in the right place. And this didn't happen very quickly. It was many hours of delay. And instead of sort of escalating it and getting this X-ray really promptly and urgently, it was just left. The patient didn't have their tacrolimus for a couple of days. And in the end, the tertiary renal centre just took the patient back again because they'd completely lost faith in us to look after this patient, sort of understandably. So we need to make sure that we understand what medications are critical, why the patient, what the issue is, and how we can resolve it. So I've said there is a policy. It does list types of critical medication and sort of what to do. Our policy is called Reduce Time from Delayed and Omitted Medication. So hopefully the nursing staff will alert you if they're unable to give something, but look on the drug chart as well. You'll need to action it, you'll need to escalate it, you'll need to document the plan in the notes. Moving on now, we do have a good resource now called the Prescribing Guide. So this is really useful information on what is non-formulary in our trust and why. So you access it from the Knowledge Centre, and it looks a bit like this. Outpatient prescriptions. So I don't think as junior doctors you would do too much prescribing with outpatient prescriptions, but if you do, then just bear in mind that it's a minimum of 2 weeks supply, except for courses. So we would supply, generally we would supply the full course, otherwise we'd just supply either an OP or 2 weeks. We only want to be supplying new or changed drugs, so the GPs can take care of repeat medication. But also bear in mind that if it's unlicensed or off-label, then the GP may not prescribe it. It's not a way around the formulary, so if you want to prescribe something that isn't on our formulary and you think, oh, I'm going to do a green prescription that they can take outside to Boots, then actually they do know about that and we can get fined for that. So just going on the last couple of slides now, we were asked to think about common prescribing problems that we see in our clinical practice. So obviously prescribing and clinical decision making is a learning curve, but just bear in mind these following issues that that we sort of came up with when we were asked to talk about these. So just going through the list, ensure you're prescribing for the correct patient. It sounds obvious, but mistakes are made. It's easy to make these sorts of mistakes when you're busy and stressed. Duplications, so hopefully you wouldn't prescribe paracetamol on the regular side and on the PRN side, but what unfortunately does happen is patients will already be on paracetamol on the PRN side, and then different doctors will come around on a different day. The patient might be complaining of pain, and then they'll write out the paracetamol on the regular side, not checking that it's actually already on the PRN side. So that obviously that needs to be crossed off if you think the patient needs regular paracetamol. Insulin, so as we've said before, it needs to be prescribed by brands and it needs to be prescribed correctly. So we do see some mistakes, like things like patients having Nova Rapids at completely separate times to their meals, and bear in mind that the meal times in hospital are different to the meal times that the patient might be having not in hospital. CDs, we talked about the legal requirements. We have already talked about not leaving contact details on TTOs. Renal patients, so sometimes we see renal patients that have got CKD or they're coming with AKI, and in these AKI patients that they're still on nephrotoxics and dose adjustments haven't been made. That's quite a big part of our role, really, making dose adjustments in renal patients and then putting them back up again if the renal function improves. We see transcribing errors fairly commonly as well, so missing NOACs on TTOs. So that is obviously our job to pick it up, but we're also only human as well. So if we don't spot that you've done that and the patient goes home without their NOAC, then obviously that can lead to serious consequences. So not prescribing appropriately for the patient's current clinical condition. We do see sometimes for ticaplanin, for example, for sepsis of unknown source. So hopefully you're aware that ticaplanin is quite a specific antibiotic for gram-positive infections. It's not going to cover gram-negatives, so it's not appropriate antibiotic for a sepsis of unknown source. Gentamicin doses, we don't go above 400 milligrams, and not withholding medication when they should. So things like if a patient comes in with a markedly raised CK, you should hold the statin until that's normalised. Just a word now about doctor's own prescribing policy. We are only registered to be a pharmacy for patients of our trust, so we cannot accept self-prescribing. So if you haven't already found a GP, then obviously find one. If you need to buy something over the counter, then we've got the Health at Work shop. We've also got in the outpatient ENH pharma, we've got the P medication. So if you want to come and buy something, that's absolutely fine. Otherwise, it's Socky Health or ED, and then obviously then you would become a registered patient of the trust. So I want to end on useful resources because there are a lot of things that can help in your first job as doctors. So medicines information, as I said, are for more complex queries. You can reach them on 4969, either a bleep or an extension. The summary of product characteristics, so this is on the EMC, the Electronic Medicines Compendium, and this is, you can access it on any trust computer. It doesn't need any logins or passwords, and it's more of a detailed monograph than that which you would find in the BNF. It does only contain license information because it's direct from the manufacturer, but if you want to know a bit more detailed information that the BNF isn't really telling you, then the SPCs are a good place to start. And if it's an IV query, then the Medusa IV guide is really useful. That's my sort of go-to guide, really. It does require a username and password, though, and we'll go through that on the next slide where I've got a screenshot of it. And finally, your ward pharmacist, get to know them, get to know their bleep. They're a really good source of help for you. So this is the screenshot for the UKMI Medusa IV guide. It's really clearly laid out. And the username that's just come up on the screen there, ENH Nurse, and the password is Lister1, capital L, all one word. So that is the content of my presentation. If you do have any questions, then that is my email address. Please feel free to email me. If I don't know the answer to something, then I usually know who to speak to or where to look. I'd also love any feedback that you've got. If there was something that wasn't covered that you would like to be covered, very happy to do another of these recorded sessions. As I said at the start as well, there is some more things still to come as well. So we've got an antibiotic presentation that the antimicrobial pharmacist, specialist pharmacist has written, and I'm hoping that we will get a recorded version of those slides soon, and we'll send you a link separately, because obviously this presentation hasn't really covered antibiotics at all, because we've got this separate presentation by her. We have also got some interactive prescribing exercises, so hopefully in the next couple of weeks I can get those out to you, and then have you can try and complete them, and then we can have some kind of interactive, maybe in small groups. It can be online at a time of sort of mutually convenient time, and we can get some learning done that way as well. So I know it's strange times, and usually I wouldn't be talking to you like this over online with these slides, but I hope that it's been useful, and like I say, anything that you want covered or any questions, then please email me. Okay, thank you very much.